Okay, so I think we can probably get started. So, hi everyone, I'm Karina Kolak. I'm assistant professor at the University of Manitoba in Canada, and I currently co-chair the ILIMS Global Epidemiology Conference along with Dr. Ethel Kayampi. And so what we're going to be doing today is actually just passing off my baton on to the next co-chair. So that's Anna Sibalza, who's also in attendance today. So for the next meeting, Anna and Ethel will be co-chairing going forward. But feel free to email me with any questions if you want to get in contact with previous speakers or anything like that. Of course, feel free to email me. But other than that, we can get started with our great list of speakers today. So first up, we have actually someone from my own institution. So Dr. Julia O'Mahony is at the University of Manitoba. Today, Julia is going to be talking about group-based trajectory modeling to look at health-related quality of life in people with MS. And so Julia is currently a postdoc at the University of Manitoba with Dr. Ruth Ann Mary. And so she previously completed her doctoral studies at the University of Toronto with a focus on health-related quality of life in kids with MS and their parents. So Julia, without further ado, you can please go ahead.
Great. Thank you, Karina, and everyone else for joining today. It's great to see some familiar faces and some new faces as well. As Dr. Kowalik mentioned, I'm a postdoctoral fellow at the University of Toronto, but I am joining you today from Toronto in Canada. And I'll be discussing group-based trajectory modeling to study health-related quality of life of people with MS. The work I'm presenting today was published online in Neurology last week and is open access in case anyone would like to refer to the original article. And I'd like to highlight that I'm presenting this work on behalf of my co-authors, including my postdoctoral supervisor, Ruth Ann Mary. People with MS report lower health-related quality of life when compared to the general population and those with other chronic diseases. Most studies of health-related quality of life in MS to date have been cross-sectional, and the few longitudinal studies have focused on population average changes over time without accounting for potential heterogeneity in health-related quality of life outcomes. The objective of our study was to identify physical and mental health-related quality of life trajectories among people with MS, and early risk factors for membership in the trajectory groups with the worst health-related quality of life. Based on the heterogeneous outcomes we see across other MS outcomes, as well as the findings of the prior health-related quality of life studies to date, we hypothesize that there would be distinct physical and mental health-related quality of life trajectory groups, and that membership in the groups with the worst health-related quality of life would be associated with greater physical impairments and greater fatigue at MS diagnosis. Participants in this study were enrolled in the North American Research Committee on Multiple Sclerosis Registry, commonly known as the NARCOMS Registry. Information was collected from participants in NARCOMS at enrollment and updated semi-annually thereafter. Analyses for this study were approved by the IRB at Washington State University. Actually, that's Washington University. And inclusion criteria included enrollment in the NARCOMS registry within 3 years of MS diagnosis, to allow us to create a virtual inception cohort to reflect the common clinical situation when people with MS first engage with MS-specific care and may be evaluated for risk factors for membership in poor health-related quality of life trajectories. Most participants in NARCOMS reside in the US, and we know that health-related quality of life may vary between countries. Because we didn't have enough participants from non-US countries to account for between country heterogeneity, we limited inclusion to MS participants, or to US participants. And we limited inclusion to participants who had 3 or more health-related quality of life observations in order to ascertain non-linear trajectories, with 3 health-related quality of life observations being needed to ascertain a quadratic polynomial. Demographic and clinical characteristics were collected from participants, including sex, date of birth. Race was collected because it's a social determinant of health associated with outcomes among people with MS. education, income, year of MS diagnosis, age at MS diagnosis, year of MS symptom onset. Physical impairments were measured using the self-reported patient-determined disease steps, which ranged from 0 to 8, with 0 being normal and 8 being bedridden. And the the patient-determined disease steps is highly correlated with the physician-scored EDSS. We also collected MS disease scores. Fatigue was captured using performance scales, and comorbidities were queried. Health-related quality of life was queried between 2004 and 2020 using the RAND-12, which can be scored to ascertain physical and mental health-related quality of life score separate from one another. For this analysis, we used a group-based trajectory modeling approach, which is a somewhat novel modeling approach that employs finite mixture modeling to identify subgroups within a population with similar changes in a phenomenon over time. The phenomenon, of course, that we were interested in this study was health-related quality of life. I've included the reference to a somewhat seminal paper for this methodology in case anyone is interested. And I'll also include my contact information should you wish to reach out to me with any questions. Group-based trajectory modeling differs from regular linear regression, which assumes a single underlying population and a single average probability trajectory with an associated set of variance parameters measuring population variability around a single mean trajectory. Group-based trajectory modeling is particularly valuable when modeling outcomes in diseases with heterogeneous outcomes, such as MS, where subpopulations with different behaviors may exist. For this analysis, we identified two different sets of group-based trajectories, one for physical and another for mental health-related quality of life. We assumed normal distribution censored at 0 to accommodate the continuous health-related quality of life outcomes. We evaluated multiple models with varying numbers of trajectory groups and trajectory shapes with variable numbers of or varying polynomial orders. There are several different factors that we considered when choosing the number of groups, the polynomial order, and the trajectory model fit. We also evaluated risk factors for membership in the trajectory groups with the lowest mental or physical health-related quality of life using multinomial logit modeling. This was an extension incorporated into the trajectory estimation, which is an extension that can be employed with SAS or Stata. I believe there's also a plugin for R and other software as well. And the multinomial logit model was estimated simultaneously with the parameters determining the trajectory shapes. So the multinomial logit parameters actually include the probability of group membership. And we relied on five-fold cross-validation to validate the stability of the latent classes we identified. Among the over 40,000 people who were enrolled in the NARCOM registry, 4,888 met the inclusion criteria for this study. And those participants who met the inclusion criteria completed over 57,000 quality of life questionnaires over the 27-year period after their diagnosis, with a mean of 12 questionnaires per participant. Our ultimate cohort was similar to the general MS population, with most participants being female, and over half the participants were over 42 years of age at the time of MS diagnosis. There was a median diagnostic lag of 5 years, and over half of participants were followed for just over under 4 years at the time of their first health-related quality of life diagnosis. Only 11% of participants had a progressive disease course at enrollment, and over half participants had mild to moderate or normal to moderate physical impairments. Similarly, over half participants had minimal to mild fatigue. Most participants were white, 70% of participants had some sort of post high school education, and about 46% of participants had an income of over 50,000. Notably, 58% of participants had one or more physical comorbid disorders, and 32% had one or more physical mental health disorder. Using group-based trajectory modeling, we identified 5 distinct physical health-related quality of life trajectories. The average or mean quality of life, physical quality of life score on the RAND 12 is 50 with a standard deviation of 10. So the group of light blue here, which represented just over a quarter of participants, was labeled chronically low and somewhat stable over time. As you can see, the confidence intervals around all groups were fairly tight up until the 20-year mark, and we're still fairly tight thereafter. There was another group that experienced an early decline and then a late rebound, represented here in light gray. The orange group was labeled as moderately low and stable throughout time. And then the red group was early low and then was reported normal health-related quality of life as of about the 10-year mark post-diagnosis. And then the group represented in black here was interesting to us because these participants reported somewhat persistently normal health-related quality of life almost up until the 15 or 20-year mark and then declined, although the confidence intervals around the 20 to 25-year mark were wider. Participants in the group with the chronically low and stable quality of life, which we deem to be the worst quality of life group among these 5 groups, had an older age at the time of enrollment in NARCOMS, had greater physical impairments, and greater fatigue. And notably, these participants in the chronically low group differed in terms of these 3 factors from all other groups, including this orange group that was still considered to have low and stable quality of life. Similarly, we use group-based trajectory modeling to identify 4 distinct mental health-related quality of life trajectories. We once again identified a chronically low group. The mental health-related quality of life scores, I should clarify, were similarly had a mean of 50 and a standard deviation of 10 using the original RAND data. So again, the 50 was considered to be somewhat normal, and the red group was considered therefore to have chronically low quality of life. The light blue group was considered to have chronically low as well. So we distinguish the red group as chronically low as compared to the light blue group. The group in light gray had early low and then somewhat normal quality of life as of the 10 to 15-year mark. And then the group in black had chronically normal quality of life. Once again, we can see that group membership was ranged from about 18% of participants to 32%. And the confidence intervals, once again, for the mental health related quality of life were somewhat stable again, or tight around the estimates. The participants in the group with the chronically lowest mental health related quality of life differed from all other groups in terms of having an education less than post-secondary and an household income of less than 50,000 per year. We found that only 8% of participants were members of both the worst physical and the worst mental health related quality of life groups. And similarly, 8% of participants were members of both the best physical and those mental health related quality of life groups. So there were about 84% of participants whose mental and physical health related quality of life did not necessarily align as being in the worst or the best groups for both. The cross-validation analysis we applied revealed substantial overlap between the cross-validation estimates and those that we estimated using our entire original data set. So overall, we found that group-based trajectory modeling highlights the heterogeneity in the MS population and the overall importance of longitudinal data sets. Factors associated with membership in trajectory groups are consistent with the findings of prior cross-sectional or the few longitudinal studies. And people who are younger at the time of MS diagnosis have better physical health-related quality of life, but worse mental health-related quality of life. We want to note that participants in the NARCOMS registry are volunteers, so the findings of this study may not necessarily be generalizable to all people with MS. And we were unable to account for the number, type, or severity of comorbidities, which may be associated with both physical or mental health-related quality of life. We found that risk factors for membership in the group with the worst health-related quality of life are easily identifiable by clinicians and potentially amenable to change. And we wanted to highlight that some of the social determinants of mental health may be responsive to interventions, including income supplements, greater access to green space, and supported education for young adults, particularly those who are still trying to complete their education, and specifically post-secondary education at the time of MS diagnosis. I want to highlight again that this work was a group effort from my co-authors and recognize the CMSC, the MS Society of Canada, and the team at NARCOMS for providing this rich data source. I'd be happy to take questions now or to connect via email.
Great, thank you so much, Julia. That was really interesting. And thank you for keeping exactly to time. Nice work. I'm just going to open up the floor to any questions that we might have from anyone. You can also send a chat message too to either of us and we can read it out, or go ahead and just use the floor.
Hey, I have a question. So you were able to use information that leveraged questionnaires that were exactly same versions throughout up to 20 years, which is amazing.
Yes.
Has there been changes in these questionnaires over time that you're aware of? Because sometimes there's, tools that kind of change because people figure out what's more appropriate wording for some of the questions and so on. So I wonder whether the tools that have been available for the past 20 years have remained completely unchanged, because that's amazing.
Yes, so the NARCOMS definitely benefits from a rich data source and somewhat consistent questioning. Some factors have certainly changed over time, and part of NARCOMS is to query specific questions over and over again, but then also add specific components. So the comorbidities were queried at different time points and not necessarily consistently. So sometimes participants were queried about mental health diagnoses overall, or specifically queried about, for example, there was one NARCOMS update that specifically questioned whether or not people had optic nerve involvement, for example. So at each time point, participants were questioned whether or not they've ever been diagnosed with one of the conditions and what the year of the diagnosis. So we were able to go back and ascertain whether or not people had any of these diagnoses at the time of questioning, but people weren't necessarily questioned at the time of enrollment or within 3 years about every single diagnosis. That may have fluctuated over time.
Yeah. And so in terms of, because you have so much data, I'm sure you've looked at that, or you're planning to look at that, try to cross access to disease-modifying therapies, for example, and the trajectories?
Yes, we haven't looked at that now. Now we're starting to employ longitudinal analysis to look at factors associated with the shape of the trajectories and whether or not someone who is assigned to one trajectory and has the associated risk factors for membership in that trajectory might actually change the direction of their quality of life over time.
That's great. Thank you so much for the question and the answer there. Just going to admit one more person in here, and I'm just going to pass it off to Ethel to introduce the next speaker. Thanks, Julia.
Thank you.
Thank you, Karina. Thank you, Julia. Our second speaker is Antonia Ceccarelli. She's currently a consultant neurologist at the Epicura Center Hospitaller in Belgium, and she works as research physician at University Hospital in Brussels. She's an Italian native. She earned her medical degree and neurology residency in Bari and her PhD in Milan. And later she became a faculty at the Harvard Medical School and then the Case Western Reserve University and at the Cleveland Clinic in Abu Dhabi. And today she will present her talk titled MS and CNS Inflammatory Related Disease in the MENA region, a glimpse into my research studies in the United Arab Emirates. Welcome, Antonia.
Thank you. Thank you, everybody. I'm very happy and honored to be here. I will share my screen now. Share screen. Did you see my screen? Yes. Yeah.
Not yet.
Not yet. Now?
Yes.
Okay, perfect. In this presentation, I will review the epidemiology of MS and CNS inflammatory related disease in the MENA regions with a glimpse into my research studies, the research studies that I performed when I was working in the UAE. The MENA region is a region that includes countries from the Middle East and North African regions, and these areas have been historically considered to have a low rates of multiple sclerosis prevalent and incidence. However, recently mounting research evidence is showing that the prevalence and incidence of multiple sclerosis is increasing conspicuously worldwide, and this is the case also in the MENA region. As you can see from the Atlas, Global MS Atlas, and the MENA regions, you can see here in clear blue, falls into the moderate risk zone for multiple sclerosis. As for the worldwide MS prevalence, the increasing prevalence of MS and the incidence of MS in the MENA region is being driven by the female sex, as you can see from the studies of Dr. Rugani and Dr. Schiss in Abu Dhabi. But which are the factors responsible for changes in MS epidemiologies? Experts are raising different hypotheses. We all know that MS is a complex pathogenesis where environmental, genetic, and immunological factors play a role. So the rise of MS prevalence may be in the MENA regions can be partly due to changes in environmental risk factors, such as for example, urbanization, migration from rural areas to city, and consequently low sun exposure, low level of vitamin D, westernization, changes in dietary habits, low level of vitamin D, increasing BMI, increasing smoking habits. But I also added here a blue balloon containing what I call as medical contribution, in the sense that the detection of MS in the MENA regions is maybe increased by the increased use of MRI, the utilization of the new diagnostic criteria for MS, the increasing number of MS trained neurologists and MS clinical researchers, and also the improved medical care that has been developing in the latest year in the MENA regions, and the availability of all DNT medications. Indeed, the increasing of medical and research expertise in the MENA regions has brought to increased number of studies in regarding of MS epidemiology. As you can see from these slides, I put a star on the studies that have been done before the year 2000. And as you can see, there are few studies that have been done before the years 2000, while the majority of the studies have been done after the year 2000. And there is a link between the increasing of MS prevalence and the years of publication of these studies. For example, here we see that the lowest prevalence is for the region of Duman, while highest prevalence has been found in 2016 in Abu Dhabi from Dr. Schiss, that has found a prevalence of 64 cases. Regarding the incidence of MS in the MENA region, only few studies have been performed, and mostly are from Iranian countries, and Iranian countries show also the highest incidence of MS, and almost the same incidence has been found for countries like Bahrain, Jordan, Turkey, and UAE. In the UAE, in Dubai, we observed 7 cases per 100,000 person years, and in Abu Dhabi, Dr. Schiss collaborator observed 6 cases per 100,000 person year. From all these studies were all single center All these studies were almost single center hospital-based studies, while recently a meta-analysis was performed and have obtained the latest pooled MS prevalence in the MENA region as ranging around 52. Also, have obtained the female proportion, pooled female proportion as raising as 0.7, and the pooled age at onset was almost around 29 years old. Furthermore, this meta-analysis showed that the most common phenotypes of MS in the MENA region was the relapsing remitting phenotype. Very recently, a registry as a part of the MS-based international registry has been created for the MENA regions from the effort of Professor Yamut and his collaborators, and the results, and they analyzed all the data from a total of 11 centers contributing around 7,000 patients as of December 2018. And from this analysis, the results were almost in line with the analysis of the previous meta-analysis. So basically, in summary, they showed that compared with the MS in the West, MS in the MENA regions seems to have a younger age at onset, lower proportion of primary progressive MS, a more aggressive clinical course linked to a shorter time to reach EDSS-6 in relapsing remitting patients. Very few studies have looked in the MENA regions at the MRI imaging characteristics of multiple sclerosis. I pulled out this study that has been performed in Abu Dhabi. It's a single center hospital based study with retrospective studies. They have shown that Emirati patients at the onset of the disease have high lesion load in the brain and in the spinal cord. Even a formal comparison with a group of expats or people from patients from Western countries were not really performed. From the work of Professor Yammout, we also got the information that in the MENA region, all the DMT treatment are available for patients with multiple sclerosis, and still the first line treatment are accounting for almost half of the DMT that have been used, but the number of oral medication is also increasing. The use of oral medication is also increasing in the MENA regions. Interestingly, mostly in Iranian countries, there are still locally manufactured generics that are used for treating MS. Although MS treatment are all available in the MENA regions, only few studies have focused on data on efficacy and safety of treatment in MS patients. The majority of these studies were done using fingolimod and are from Lebanon. And here I pulled a study that my group performed in Abu Dhabi, in which we analyze 30 patients, Emirati patients with multiple sclerosis, were commenced on fingolimod from 2015 at our center, and who received treatment for at least 6 months. Compared to previous trials, Western trials and real-world studies, our population was showing a younger age at onset, a shorter disease duration, higher BMI, and higher rates of comorbidity. In terms of efficacy, we showed that overall a reduction of annualized relapse rate was observed around 72%, and 76% of MS patients showed no relapse post-treatment, and 62% of MS patients was free of MRI activity. Regarding safety, patients showed only few side effects, and only 33% of patients showing adverse event. These adverse events were all transient and consisted of leukopenia, slight increase in liver enzyme, fatigue, asymptomatic bradycardia, headache, and air loss. We observed air loss in only one patient. After we look for familial multiple sclerosis, the MENA region is a region in which there are very few. There've been very few studies performed on familial multiple sclerosis, and a recent meta-analysis have pulled all the familial multiple sclerosis studies from Western and Eastern countries and showed that the pooled prevalence of familial multiple sclerosis is around 12%, a little bit lower than the previous familial prevalence. Familial multiple sclerosis is higher in pediatric patients, that the mean age of onset is around 29 years old, and that there are very big significant difference in the prevalence of familial multiple sclerosis between geographical areas. To show our studies, there have been already 2 studies that have seen the prevalence of familial multiple sclerosis in Abu Dhabi, and have shown that this prevalence was around 12% in Abu Dhabi and almost 19% in Dubai. But there were no study that show characteristic, clinical and demographic characteristic of familial multiple sclerosis compared to sporadic multiple sclerosis. So we compare these 2 groups of 24 familial multiple sclerosis versus 74 sporadic multiple sclerosis, and the majority of our patients were females, were smokers, were overweight. 24% have familial multiple sclerosis and 83% were Emirati patients, but we were unable to show any difference in this analysis. Obviously, the study was limited by the small sample size, the retrospective nature of the study, and the anecdotal notion of familial multiple sclerosis. Moving to NMO spectrum disorders, we all know that NMO is a rare disease worldwide, and only few studies that are here have been focused on NMO in the MENA region, and as you can see are almost from Iranian countries and only one from the UAE, and all these studies show a greater prevalence and incidence of NMO spectrum disorder compared with the larger studies in Western population, as you can see here. We then decide, since there were no studies assessing clinical and demographic and radiological characteristics of NMO patients in MENA regions, to analyze a case series of 5 patients with seropositive NMO. All patients were females. The mean age at onset was 41 years old. The clinical onset was mostly represented by acute myelitis, and only 1 patient had optic neuritis, while the average of further relapsing was 3. Both myelitis and optic neuritis were either as a solitary or in combination with other phenotypes. And at follow-up, 80% of patients develop myelitis, while some develop optic neuritis. All patients had comorbidities, 67% had autoimmune comorbidities, 60% had vascular comorbidities, and 20% had SIADH. High comorbidity burden was observed only in two patients. And the average disease duration of this group was 12 years. As expected from the radiological point of view, 85 of patients had upper cervical cord and thoracic transverse myelitis with selective damage of central gray matter of the cord. As you can see from the slide, we observed only one patient with no major cervical damage, mostly thoracic, and we also observe macroscopic atrophy in some of the cases, considering that all these patients were patients with a disease duration longer than 9 years. We also were able to register an acute exacerbation with gadolinium enhancement of optic nerve and of lesion at thoracic cord. In 4 cases, the brain MRI showed white matter hyperintense lesions not meeting the criteria for MS, some ependymal lesions, some maybe cortical spinal tract bilateral lesions, and some lesions of the splenium of the corpus callosum. We were not able to detect, even in patients with area postrema syndrome and SIADH, lesions involving the dorsal pons, medulla, and the encephalus. So to conclude, MS and CNS-related disease prevalence and incidence have risen over the years worldwide, as well as in the MENA region, especially in females. To date, overall, the MENA region has a moderate average MS prevalence, and diverse factors are contributing to this increased prevalence and incidence. Obviously, more research studies are definitely needed in the country. Compared to Western MS, we observed younger age at onset, relapse course, heavy MRI lesion loads, even this was only based from one study, more aggressive disease course, lack of clinical and demographic differences between sporadic and familial multiple sclerosis. It seems from the studies that MS treatment that are widely used in Western are efficient and safe in the MENA regions, but still more research studies are really needed. And regarding NMO spectrum disorder, we noted that there was maybe a greater prevalence and incidence of NMO, but we observed similar clinical and MRI characteristics. These were also based on single studies, so more research studies are really needed. Thank you.
Thank you so much, Antonia, for your presentation. We will follow with the final presentation, and then we will get into the questions by the end of the third talk. Okay? Please, Anna.
Okay, thank you, Ethel and Antonia. Our next speaker, which I'm very happy to present, is Francesca Bovis. She's a postdoc researcher in biostatistics at the University of Genoa in Italy. Her research focuses on a statistical analysis of medical data with particular focus on methodological problems in the study of MS. However, she's also researching on pediatric rheumatology, spinal muscular atrophy, infectious disease, and physiopathology of human reproduction. She's gonna give us the presentation about how we can reinterpret clinical trials in children with MS using the Bayesian approach. So welcome, Francesca, and thank you very much. You can start now.
Okay.
We were saying correctly.
Can you hear me?
We can hear you.
Okay, super. So maybe I can share my screen.
Yeah, perfect. You can start.
So you can see my screen.
Yeah.
Oh, okay, super. So thank you for inviting me for the presentation. Hello, everybody. I am Francesca, and I am a biostatistician working at the University of Genoa. And my talk tonight, okay, for me tonight, probably for some of you it's still morning, is about the possible use of Bayesian approach in reinterpreting clinical trials in children with multiple sclerosis. And these are my disclosures. So as probably all of you know, to assess the efficacy of drugs that are already approved for adults in the pediatric population, the FDA and the other regulators still require standard phase 3 trials. Even though the prevalence of the disease of the multiple sclerosis in children is low, and even though there are no compelling biological or clinical reasons indicate that the evidence obtained in adults should be ignored when decided treatment strategies for the pediatric population. So this regulatory requirement might not benefit children, as it results in long-lasting, slow recruiting, possibly underpowered trial, and might limit the number of the registered drug for children with multiple sclerosis. So you have to take in mind that trials for pediatric multiple sclerosis typically enroll around 200 patients, whereas other trials for the same drug typically enrolled 1,000 patients. So we applied a Bayesian approach for estimating the plausible effect of teriflunomide in children with MS, where the results of the TeriKid study, that is a negative trial assessing teriflunomide in children, was integrated with the available knowledge on teriflunomide in adults. And so let's start with a very brief recall about the frequentist approach. I hope to be enough clear. So in the frequentist approach, every time we start an experiment, for example, if you want to investigate that a new drug is better than an old drug or better than placebo, we start with the idea that the null hypothesis is true. And so we start assuming that the treatment we are testing doesn't work. So this is a very counterintuitive approach, but it is what we do every time. So we begin by assuming a null hypothesis to be true before data are collected. So we assume that there is no effect at all of a particular treatment on the study outcome. Then investigator collected data, analyzed the data, and ask how surprising is my results if there is actually no effect of the treatment. So then we calculated the p-value, that is simply the probability of obtaining another data set at least as extreme as the one collected by chance alone. So in other words, if we had run the analysis and got a p-value, for example, of 0.03, then there is a 3% chance to see the same results if the treatment doesn't work. And usually we set the cutoff to 5%. So if our p-value is lower than 5%, we can say that the probability to see our results if the treatment doesn't work simply by chance is low. And okay. And the p-value does not say how probable the null hypothesis is given the data. And even though we prove that the null hypothesis is false, we can only say that the probability to see the same results if the treatment doesn't work is low, but does not prove the alternative hypothesis to be true. And in general, what we really want to know is the probability of the alternative hypothesis given the observed data. So, I mean, we want to know the likelihood that the treatment caused the effect. And the Bayesian method is more intuitive than the frequentist approach and allow us to update probabilities based on data and the past knowledge. So let's try to introduce the Bayesian method using a very simple example. So you are familiar with sensitivity and specificity terminology. And in this example, sensitivity, probability of having a positive test if we had the virus is 100%. And the specificity, that is the probability of having a negative test if we do not have the virus, is 99.9%.
Yeah.
So,
and then did you see, I'm not sure if this went to you, Jason.
Sensitivity and specificity can be seen as the performance measure of a test. But what we really want to know is the probability of having the virus if my test is positive. So to answer this question, we had to apply the Bayes theorem that you can see below in the slide. And through this formula, this theorem, this Bayes theorem, we can update probabilities based on our data and the past knowledge, so using some prior information. In the example that you see before, to calculate the probability of having the virus if my test is positive, we need to know the prevalence of the infection, that is the prior information. So in our example, the prevalence of the infection is 2%. And combining this prior information with the evidence of the test results using the Bayes theorem, we can find that the probability of having the virus if the test is positive is 95%. So in other words, if in our population, the prevalence of the infection is 2%, the probability of having the virus if my test is positive is quite high. I mean, I'm quite sure with the 95%, I'm quite sure to have the virus. And of course, you can see it's intuitive that changing the prevalence of the disease, of the infection, also the probability will change. So how we can translate all this approach in the clinical practice? We apply the Bayesian approach to the TERIKID trials that investigated equivalent to the adult dose of teriflunomide versus placebo in children with multiple sclerosis. And this trial is a clear example of an underpowered trial, and is a clear example of apparent failure of a trial if failure is defined as a non-significant p-value for the primary endpoint. And as you can see from the Kaplan-Meier curves, the effect of the treatment is quite huge. I mean, the hazard ratio is equal to 0.66. And this means that there is a 34% reduction in time to first confirmed relapse with teriflunomide compared with placebo. But as you can see, the p-value is equal to 0.29, so it's higher than 5%. And the FDA did not approve teriflunomide for children in the United States. Now I'm showing you the results of two randomized phase 3 trials conducted on adult population, the TEMSO and the TOWER studies. And this study detected a significant reduction in time to first confirmed relapse with the teriflunomide compared with the placebo. And the TEMSO lead a 28% reduction. And in the TOWER, we observed a 37% reduction. The first thing you can see is that TeriKids enrolled 166 patients, whereas adult trial for the same drug enrolled more than 1,000 patients. So as you can see from this table, the effect of the treatment is more or less the same. What is really different is the number of the patient enrolled. So as I said before, since there are no compelling biological or clinical reasons indicate that the evidence obtained in adults should be ignored in the pediatric population, we can use these results, the results from the TEMSO and from the TOWER trials as a priori information. And to make them strong, we summarize the results using a meta-analysis. The prior distribution obtained by pooling the results of the two trials in adults was centered at another ratio equal to 0.68. And then we incorporate this prior information with the data from TeriKids using the Bayes theorem. And these are the results we obtain. The posterior estimate of the efficacy of teriflunomide obtained by combining the prior distribution with the TeriKid results was equal to 0.67, indicating that its most plausible effect is about 1/3 reduction in the incidence of relapses, and that the probability that teriflunomide has no effect in children is very low, equal to 0.03. And the major criticism of the Bayesian approach focuses on the subjectivity involved in the generation of the prior distribution. I mean, one can complain that pediatric population is not the same as the adult population. And to overcome this problem, we downweighted the prior distribution to 50% and to 75%. I mean, we increase the variability of the distribution, diluting the effect of the treatment in pediatric population by 50% and 75%. And also you can see from this slide that also increasing the variability of the prior distribution, the posterior hazard ratio estimate was simply 0.67. So the reduction is 1/3 in the relapse incidence. And the probability of no effect was 0.03. So in conclusion, the TerryKids trial was negative when analyzed using the frequentist approach, even if the treatment effect on children was on the same size as the effect on adults. The Bayesian approach offers one way to overcome the problems of evaluating new treatment for MS children when randomized trial of the same drug have been already conducted on the adult population. And in contexts where we have many available drugs for adults with clear difficulties in approving them for children following the standard pathway, it is unethical not to consider statistical instruments that are well accepted and validated in other fields, for example, like in the oncological field, and then can help to improve the clinical care of children with multiple sclerosis. So thank you for your attention.
Thank you very much, Francesca, for this very interesting talk. Thank you very much for sticking to time. And now we're open to questions of Francesca's and Antonia's talk. If anyone has a question. Okay.
I have one question for Antonia. There. So we have very similar populations from very far away, and we also have some generic drugs. So do you have any real world evidence comparing the two drugs, the generic and the novel drug? For instance, fingonimod or other drugs in your population? I think you're muted.
Actually, no, we didn't have done this comparison, but it will be very interesting to do it actually. Yes, will be an adding to the science for sure. We will maybe plan in the future.
Mm-hmm. Thank you.
Thank you.
And then I'll have a question for Francesca. Well, as you said, assuming that both children, mainly over 10, and adults have the same pathophysiology through the lifespan, and we know that many drugs are efficacy, they're approved for adults. Would you agree there are some, the FDA or the FDA, I think, approves in diseases such as epilepsy, agrees that, as we are saying here, that children and adults have the same pathophysiology, need to approve or to validate this efficacy in children, and they only do pharmacokinetic and safety studies. Do you think this is an option? Do you think this is an option with Bayesian methodology, which I really think was very interesting?
Yeah, I mean, it is exactly the point. I mean, I think that once we agree that, okay, children are not small adults, probably there are differences between children and adult population. But if we assume that there are no compelling biological or clinical reasons, and if we can consider to put our attention on the safety instead of the efficacy of the treatment. I mean, if we can assume that the efficacy, maybe with a small sample size, if the treatment is more or less the same, okay, we can give more attention to the safety. That is the more important things if we try adult drugs on the children.
Okay, thank you very much. And also another question: do you have, do you know any other disease or clinic that they're using this methodology to approve, that the FDA accepts this?
For example, for the oncology. In the oncology field, the Bayesian rules, the Bayesian approach is quite used.
Yeah, this is very useful to study. Thank you very much. Does anyone have any other question?
I think we're okay for today. Thank you everybody for connecting. I know many of you are on vacation, so thank you very much. Please write to us, to any of us, if you're interested in presenting in the next meeting. And we'll be saying goodbye to Karina, of course, and welcome to Anna for the next season of this Global Epidemiology Group.
Thank you. Bye.
Bye.
Bye.